I think we'll see that the shift will take place to move towards Tenecteplase as the standard of care, because it, irrespective of the potential superiority, I think even non-inferiority is sufficient to make this a better treatment, because logistically it just makes a lot more sense to give single bolus injection. We move around a lot of patients for thrombectomy, and if we're doing that, it is much easier if you're doing it with Tenecteplase. And I think the experience that some countries have had, like New Zealand and parts of the United States, has been that it has speeded up the transfer process quite significantly. In some cases, it has also shortened door-to-needle times, because it is a lot more straightforward to mix and deliver treatment, and you can give a quick injection easily in a CT scanner, for example, whereas it's much more difficult to assemble all the necessary equipment to do the full infusion treatment for Alteplase. So that often means people move out of the CT back to another area before they can get this. So I think there are significant benefits, even if non-inferiority were the only data that we had on Tenecteplase. How quickly that can happen is logistically a little bit difficult to predict, because Tenecteplase availability at the moment is limited across the globe. That's a drug manufacturing issue, and it's because it has in the past only been manufactured for acute myocardial infarction, which is a fairly limited number of patients. Capacity to manufacture Tenecteplase is being built up, and also there are moves towards producing a dose which is more suitable for stroke patients. At the moment, the dosage is produced for acute MI, and that's a much bigger dose that's delivered. So it's problematic if you have to discard more than 50% of a vial of an expensive drug every time you're treating a patient with stroke. So the hope is that in the coming months, there will be availability of an appropriate dose and enough of it to allow the switch to happen.